Hello, everyone, and welcome to the Pediatric Oral Health Screening Module, a crash course into what you can do to improve kids' oral health by identifying and halting the spread of early childhood caries. Whether you're involved in pediatrics in some way or simply interested in helping out, the ability to make accurate screenings and collect preliminary information can be invaluable in improving public oral health. Here's what I hope to teach you today. First is the ability to recognize early childhood caries, or ECC, and make a classification diagnosis based off your findings. The second is the ability to identify risk factors for early childhood caries. And the third is to understand the benefits of the value of fluoride varnish and its application. So, what is ECC? Early childhood caries, or cavities so to speak, is defined as the presence of one or more decayed, missing, or filled tooth surfaces in any child 6 years or younger. In public knowledge, we think of caries as a dark hole in the mouth associated with pain. However, caries is a dynamic process, and that is just one manifestation, typically much later into the disease progression. Here's how the caries process works. Every tooth has some bacteria associated with it. Sugars and carbohydrates nourish the bacteria and they produce acid, which in turn demineralizes and breaks down the tooth, creating cavities. So now we know what ECC is, but why should we care? It's the number one chronic disease in children, and with that comes pain, costly treatments from repeated visits, and also a severe educational loss and attendance burden from missing out on school. ECC is actually the number one reason why students miss classes. Furthermore, in some rare cases, it's affected the ability to speak. And the disease isn't just limited to the individual, it's contagious and can be spread. It can be transmitted horizontally, meaning among friends and siblings. It can also be transmitted vertically, among parents and grandparents to their successive children. Restorations don't mean that the cavity has completely disappeared or that it cannot return. In fact, children who have cavities more often when they're younger are likely to have them as adults too. And that's where you come in. Screenings are always valuable because they provide preliminary information about the child's oral health, and you can also identify the urgency required in their care. As I stated before, the disease process of early childhood caries is a dynamic process, meaning it can manifest itself differently at every stage, and it can be at any given stage at any given time. Excluding pain, which is the key indicator of urgent care, you have different ways in which the disease manifests itself. Here's a great example. In the top right corner here, the teeth show evidence of white spot lesions. They're named so because, well, they look like white spots. White spot lesions are demineralized areas of tooth structure. This is an area that is still reversible. While acid attacks are already occurring from the bacteria hosting onto the teeth, it means that you can still do a preventative measure to prevent it from becoming true cavities. Instead, if you look at the top left here, actual cavitations, where you have physical divots into the teeth, are oftentimes irreversible and can't be remineralized. These areas will require fillings in the future. Of course, there's always the extreme end of the spectrum in which you have dark cavitations, pulp exposures, and broken crowns. These teeth will need urgent care. So with your screenings, you'll be asked to provide classifications based off your oral examination findings. Class 1 means no obvious problems, or preventative care, not restorative care. White spot lesions, for example, are not very dramatic cavitations or demineralized areas of tooth structure. These areas are reversible, meaning that they do not require restorative care and would not fall under Class 2. Furthermore, if you have small breaks in the enamel, they would also be included in Class 1, because unless they absolutely require restorative care, they remain Class 1. Suspected or possible decay would also not be included in Class 2 because, again, Class 2 is only reserved for definite breaks in the enamel and therefore restorative care. Class 2 indicates early dental care is needed. This would be an example of the cavities I showed you in the very first image. This includes caries involving definite breaks in the enamel that require restorative care, meaning they can't remineralize over time due to the extent of damage. Rampant or severe decay often falls under Class 2 as well, so long as it's not accompanied by the key alert of pain, abscess, swelling, or other signs of infection. The majority of patients that don't have access to adequate dental care typically fall under this category. Class 3 means the patient is in urgent need of dental care. Another example would be that last picture I showed you in which the patient's anteriors were completely destroyed. Any type of pain, swelling, or other signs of infection are indicative of Class 3. Furthermore, if the patient has acute injuries such as trauma to a tooth and has some kind of pulpal exposure or any kind of mobility that needs immediate treatment, it'd be coded as urgent. Now that I'm certain all of you are convinced on why we need to screen and why early childhood caries are important, it's important to learn how to screen. First, remember to be friendly and have a dialogue with your patient. A mask might be scary to some kids, so be inviting and talk to them normally about everyday things. Then, you should have them smile. You should screen the gums to check for any signs of injury, chewing pathologies, or rare oral conditions. In this stage, you can also check for any necessary ortho. If the patient has severe overjet or overbite, you may consider writing that in your classification chart. And then, of course, ask your patient to open their mouth so you can see the inside of their teeth to make a proper diagnosis and classification based on what you find. Now let's talk about applying fluoride varnish effectively using two people I've never met before. First, this extremely charming provider, wearing proper PPE, dries off all the surfaces of the teeth. This is especially important as fluoride is most effective when applied to dry surfaces. Fluoride is also most effective on smooth surfaces, which is why you should take special care of applying it to the facial and lingual aspects of the teeth. Also notice that the provider selected the maxillary teeth first. This is because fluoride varnish tastes really bad, and kids will reject the taste, especially if they're non-compliant. So it's best to start with the uppers, because then they're less likely to taste it and therefore reject the treatment. Then, with the mandibulars, it's the same idea. We apply it very quickly and very generously, and make sure that it's very dry. It's difficult for the mandibulars because once you enter the lingual side, the tongue gets in the way, there's a lot of saliva, so try your best. Now you may be curious as to what we can do about deep pits and fissures, and that's why children receive sealants. After messing with your patient a little further, just kidding, you may have your patient sit up because they've probably been collecting saliva, spit it out, which is pretty gross. Oh man, yeah. And you're all done. When you're finished with the application, remind your patients of two things. One, no eating or drinking, except water, for the next 30 minutes. Also, the patient should not brush for 12 hours post applying a fluoride varnish to get the most out of the varnish, and also because it'd be excessive fluoride. In the event that kids are scared of the fluoride varnish, follow these quick pro tips. First, let them feel the brush. Remind them that the brush is not there to hurt them. If anything, it's ticklish and you're trying to tickle their teeth. Second, just tell them it's a vitamin or a type of nail polish. This resonates better with children who have a harder time understanding what varnish is unless they're really into woodworking. But always remember, folks, too much of a good thing can be a bad thing. And when it comes to fluoride varnish, if it's not used judiciously on high caries risk patients, this is also true. Patients will manifest this condition known as fluorosis, which is an overexposure to fluoride in developing teeth, not fully developed teeth. Take a look at the bottom right corner. These teeth are the severe end of the spectrum, in which fluorosis has manifested this extremely chalky and white appearance. But in the mild ones, it almost looks like white spot lesions on the incisal edges. However, you should note that the fluorosis is symmetrical, whereas white spot lesions tend to be scattered throughout. This is a good way to understand the differences. Furthermore, if you look at the cervical areas, these are areas where children tend to brush their teeth less, and that's why white spot lesions will form. Knowing these distinctions are key to making a clear classification, because if a child has fluorosis, that means that they have too much fluoride protection, whereas if a child has white spot lesions, it means an insufficient amount of protection. Err on the side of safety when making your best judgment, but remember, the typical benefits of fluoride outweigh the harms. And that's all for our pediatric oral health screening module. Thanks for listening in, and we hope that as you go out there and continue to screen, that you'll remember the pros and cons of applying fluoride, how to properly screen, and of course, have a great time encouraging the public health fight against caries disease, especially early childhood caries. Thanks again, and take care.